This chart maps the escalating global burden of low back pain. We are looking at a baseline of roughly 619 million current cases, with prevalence climbing toward 843 million by the middle of the century. Clinically, this massive patient population is divided into two categories: specific low back pain, where a clear pathoanatomical substrate can be identified on imaging, and nonspecific pain, where a definitive nociceptive cause remains elusive. Confronted with a patient in pain, the primary cognitive trap for a clinician is geographical bias. When a patient points to their lower back, the immediate reflex is to treat the symptom as a mechanical phenomenon of the local lumbar structures. Precision diagnosis requires breaking out of that geographical constraint. To find the true pathoanatomical substrate, we have to map symptoms across three distinct domains: intrinsic mechanical conditions of the spine, systemic or non-mechanical conditions, and referred pain from visceral organs. This is why defaulting to a standard lumbar MRI for every presentation of back pain is a flawed diagnostic reflex. An MRI tuned for intervertebral discs will capture localized mechanical decay, but it is often the wrong modality to detect destructive pathologies operating outside that immediate structural framework. This localized focus explains why so much low back pain remains categorized as nonspecific. Without a framework that accounts for systemic and referred origins, a standard scan of the vertebrae may simply be looking at the wrong anatomical structure entirely. The first diagnostic domain covers the mechanical or intrinsic spinal conditions. These structural failures account for the predominant number of low back pain cases in clinical practice. This flowchart maps the primary mechanical etiologies by their anatomical origins. Discogenic pain originates from intrinsic decay. When the nucleus of the disc creates a non-complete annular tear, it triggers an inflammatory ache transmitted through the sinovertebral nerves. Contrast that with disc-related pain. If that same nucleus pulposus herniates completely through the annulus, the disc itself is no longer the primary pain generator. The extruded material physically compresses the adjacent nerve root, producing a distinct radicular pain pattern that radiates into the buttocks and down the leg. Beyond the discs, mechanical axial pain is frequently driven by direct structural failure of the bone, primarily in the form of vertebral compression fractures. Osteoporotic patients represent an extreme vulnerability here. Because their bone density is critically low, even minor axial loads, forces generated by simple routine movements, can exceed the structural tolerance of the vertebral body and induce a fracture. While compression fractures are traditionally diagnosed via radiography, subtle collapses frequently evade human detection. Deep learning algorithms deployed on standard X-rays are now matching the detection rates of expert radiologists, flagging microscopic structural failures that would otherwise be missed. Mechanical failure can also occur without any gross morphological changes. Microinstability is a pure motion syndrome where the vertebral segment fails to stabilize under load. The spine's range of motion remains preserved, but the lack of segmental stabilization triggers intense, compensatory spasms in the surrounding trunk muscles. Mechanical low back pain requires precise differentiation. A targeted treatment plan depends entirely on whether the pain is driven by nerve root compression, internal disc degradation, or microscopic structural collapse. Moving away from the vertebral bodies and discs, we have to examine the posterior elements, the facet and sacroiliac joints. Facet joint osteoarthritis produces pain transmitted by the medial branch of the posterior rami. The presentation is typically unilateral, but the inflammation can refer pain down the thigh, closely mimicking the radiculopathy of a herniated disc. Sacroiliac joint pain operates on a dual neurological pathway. The anterior capsule transmits signals via the ventral rami of the L5 through S2 roots, while the posterior joint utilizes the lateral branches of the dorsal rami from S1 through S4. This split-screen matrix compares the required diagnostic modalities for SI joint pathology. If a clinician suspects inflammatory sacroiliitis, often secondary to spondyloarthritis, an MRI is essential to capture the bone marrow edema. For non-inflammatory ligamentous conditions, ultrasound is the superior modality. Targeted ultrasound allows clinicians to evaluate the long posterior sacroiliac ligament in real time, revealing soft tissue edema and pathological thickening that plain radiographs completely miss. These mechanical failures are frequently compounded by prior surgical interventions. Failed back surgery syndrome can exacerbate existing pain or generate entirely new symptoms, driven by intraoperative errors like wrong segment decompression or deeply rooted psychosocial factors that hinder recovery. To correctly identify joint-based mechanical back pain, clinicians must move past standard X-rays and deploy targeted MRI or ultrasound to isolate the specific soft tissue drivers of the pathology. The second diagnostic domain involves systemic, non-mechanical conditions. Here, the lower back pain is merely a secondary geographic symptom of a covert, aggressive disease process. This flowchart maps the primary systemic threats engaging the spine: infections and neoplasia. The spine is highly vulnerable to infiltration. Bacterial pathogens and metastatic cells utilize the Batson venous plexus, a valveless network of veins, to execute retrograde dissemination directly into the vertebrae from distant organs. In vertebral osteomyelitis, Staphylococcus aureus typically utilizes hematogenous spread to invade the highly vascularized arterial web surrounding the vertebral bodies. If the infection spreads, it can form destructive abscesses. Epidural abscesses result from hematogenous spread into the spinal canal, while paraspinal abscesses form through direct extension into the psoas muscle from adjacent spondylodiscitis. This diagram shows the definitive MRI signature for spinal infections, which provides over 90% diagnostic accuracy. Clinicians look for a decreased signal on T1-weighted imaging, paired with an increased T2-weighted signal at the site of the infection. When investigating neoplasia, primary bone tumors of the vertebrae are rare. 90% of all malignant spinal lesions are metastatic, most commonly originating from primary cancers in the breast, lung, or prostate, and triggering excruciating axial pain as they induce osteolytic bone fractures. There is, however, a critical diagnostic exception to the MRI rule when tracking systemic disease: multiple myeloma. Because the bone marrow changes in early multiple myeloma often lack tangible contrast, an MRI frequently returns a false negative. To accurately capture the aggressive osteolytic destruction of the vertebral bone, clinicians must pivot to a CT or a SPECT scan. Systemic low back pain represents a ticking clinical clock. Selecting the wrong imaging modality can mask a rapidly spreading epidural abscess or leave an aggressive osteolytic metastasis entirely undetected. The final diagnostic domain covers referred pain. In these cases, the primary pathology is entirely disconnected from the spinal architecture, yet the pain manifests intensely in the lower back. This flowchart maps visceral diseases referring pain to the lumbar region. Acute pyelonephritis presents with unilateral tenderness and fever. By contrast, acute renal colic, an obstructing kidney stone, produces excruciating pulsatile pain referring from the flank to the groin due to renal capsule stretching. Diagnosing renal colic requires a CT scan. Standard radiography is insufficient because certain urate and cysteine stones are radiolucent and simply will not appear on a plain film. When visceral pain isn't renal, clinicians must rule out catastrophic vascular events, specifically retroperitoneal hemorrhage. A retroperitoneal bleed can mimic mechanical back pain perfectly. The distinguishing clinical markers are sudden hemodynamic instability, signs of hypovolemic shock, and a patient history involving recent trauma or active anticoagulation therapy. An even more dangerous mimic is the silent expansion of an abdominal aortic aneurysm. Because the descending aorta runs immediately adjacent to the anterior spine, the physical enlargement of the aneurysmal wall directly compresses nearby nerves and structures. The patient experiences this referred compression as severe, localized back pain. If an expanding aneurysm is suspected, an MRI takes too long. Rapid bedside ultrasound is the prioritized frontline diagnostic tool to evaluate the aortic wall before a fatal rupture occurs. When the clinical history lacks mechanical trauma or the slow buildup of a systemic infection, clinicians must immediately pivot to visceral and vascular imaging to prevent catastrophic organ failure. This 3D model synthesizes the mechanical, systemic, and visceral domains into a single, unified diagnostic framework. High-precision diagnosis fails when the lumbar MRI is used as a universal default. Relying on a single modality assumes the pathology is limited to the discs, ignoring the systemic and vascular networks that can trigger identical symptoms. Precision requires matching the suspected pathology to the exact imaging tool. Deploys CT or SPECT imaging to detect the osteolytic destruction of multiple myeloma or the radiolucent stones of renal colic. Utilize targeted ultrasound to measure the expansion of an aortic aneurysm or the soft tissue edema of a sacroiliac ligament. Reserve the MRI for its true strengths, confirming nucleus pulposus herniations, mapping the T1 and T2 signal changes of vertebral osteomyelitis, and isolating intramedullary tumors within the spinal cord. By pairing a meticulous clinical history with the exact optimal diagnostic modality, clinicians can pierce the ambiguity of nonspecific back pain, map the true pathoanatomical substrate, and stop life-threatening conditions before they progress.